Our next speaker is from the University of Washington, Courtney Francis.
Thank you. And the title of my talk is I Can't See Anything to the Right. I have no financial interest to disclose. So I also have a 35-year-old woman who complains of loss of temporal vision in the right eye. She states that she was recently hit by a cardboard box at work, resulting in a headache and some temporal field loss on the right side. She denied loss of consciousness. She went to the ER, had a head CT, which was concerning for a stellar mass, and an MRI was ordered to further evaluate the mass. On further questioning, she denies loss of central vision or problems in the left temporal or nasal fields. She endorses frequent headaches. She denies photopsias, floaters, diplopia, or other eye symptoms. Her past medical history is significant for a migraine, for which she takes a triptan as needed. She has a history of endometriosis, status post-hysterectomy, no tobacco use, and only occasional alcohol, and no significant past ocular family history. On her exam, her acuity is 20/20 in both eyes. Her color vision is intact. Her pupils are equal, and she has no relative afferent pupillary defect. On confrontational visual fields, she has temporal loss in the right eye, and it is full on the left. And her anterior and posterior segments are unremarkable, specifically no evidence of optic disc edema or atrophy. I'd like to turn it over to the panel at this point and get some comments.
No RAPD again. That's bothersome. Temporal, we need a real field, not a confrontation field, because we want to know, is it the big blind spot or not?
Can you have a temporal field defect and no APD?
Sure.
Sure, yeah.
It could just be temporal, way temporal.
Right.
We call that the temporal crescent. That means it's in your brain. That's a monocular temporal crescent. So we need the field to figure out, is this a temporal hemianopic thing? Is it a temporal crescent thing? Or is it your blind spot?
Yeah, I agree, absolutely, because you're not going to get an RAPD unless you should get an RAPD if you have a significant visual field defect that's asymmetric. But you can have a little bit of a change in your temporal field and you're not going to see an APD.
Also, if it's a retinal cause,
Right.
like a nasal retinal problem that gives you temporal loss, you may not see an RAPD.
Yeah, so no R. It's bilateral, no. No A, it's not, it's afferent. No P, it's not in the pupil pathway. Well, that means it's either in your cortex or it's in front of the pupil pathway. No D, you missed it. Choose.
Anybody who's been hit hard with a box, and I have been, you really, if you're having vision loss, you really need a dilated exam looking for commotio retinae, which is just edema. Maybe not a hole or a tear yet. It's possible that following the edema, you could get vitreous traction and later, so you got to keep listening to these patients, but I would certainly look for commotio before I'd go for a scan.
I would just add no D could be they're faking. There's no D because there's no defect. But the universal, worldwide accepted Faker field is a constricted 5-degree island. They all got together by consensus and decided this is their field. They're not going to pick anything else. They don't pick central scotoma. They don't pick the temporal crescent. Central island 5 degrees. That's what they love.
Should we be
That does
talking
not
at their
expand.
conference?
They love that field.
That does not, a central 5-degree that does not expand.
Tunnel, not a funnel.
Do you think her history of migraine could be playing a role at all in her field loss?
Everybody has a migraine.
Sure.
But in terms of a visual aura or something like that?
Well, let's see her field then. I mean, I guess it depends on the field.
Yeah, and it
If
shouldn't
you
be
see
a
if
persistent.
you see a little homonymous defect that's a residual of a complicated migraine, that's something. Otherwise, it's not relevant. Yeah.
So here's her field. So it's intact on the left side, and she has temporal loss on the right side.
Should she have an APD?
She might not.
If
it's retinal.
if it's retinal, no. If it's optic nerve, yes.
So what we would do now is we test this field with both eyes open. If it's still there with both eyes open, you're a damn liar.
I've never seen a field like this without an APD, so if she doesn't have an APD, something's wrong in this case.
No, it could be the junctional scotoma of troquere, a monocular hemianopic doodad at the junction of the optic nerve and chiasm, but you better have an RAPD.
Yeah. You need an RAPD.
You could be faking.
If this is neurological, it's got to have a.
But who fakes this? Nobody.
I have a few.
Did the patient see retina?
No. This was a work-related injury.
Oh.
Well, whenever it's a work-related injury.
She could be faking, okay, but both eyes open.
Look for commotio, and then she.
Any other testing other than the bilateral field?
Yeah, the usual things. Humphrey plus one of the three. Fundus autofluorescence, spectral domain OCT, or MERG. Pick one.
Beautiful.
So a normal RNFL OCT.
Yeah, but we want to see the peripapillary retina or OCT.
That looks pretty
You
good.
know? We're not really thinking this is a swollen optic nerve, although it could have been. I doubt it.
Does this help you, the OCT?
Yes.
How?
Well, this is acute. This just happened, right?
Within the last month.
Oh, okay.
Ah.
I mean, if this was a traumatic optic neuropathy, which it's not because we don't see the RAPD, then acutely the OCT may not change, right? It might take a while. So just having a normal OCT doesn't absolutely rule out an acute neurologic event.
No, I
On
agree.
the other hand, we know from other things that this is not neurological without the RAPD, with that degree of field defect.
Yep. I would just say the most common cause of an acute and idiopathic blind spot enlargement is acute idiopathic blind spot enlargement syndrome.
So here's her brain MRI.
No junctional lesion.
Yeah.
No lesion.
So she does have a cellular mass. It was read as 9 by 18 by 9. So it's.
You're 30, how old is this person? 35? I bet a lot of ladies have a little tented up pituitary.
Yeah, but you got to tell the patient about this lesion. I mean, it's a real lesion.
Yeah, but it's not.
Not the
it's
cause.
It's not the cause.
It's not near the visual pathway, or it's not touching the visual pathway.
You know, you remember the other person with the chiasm and it was being bent like a barbell? There's no way that thing is causing this.
Now, and can you tell the audience why you're confident of that?
Because the chiasm is like
Well, can you point to the chiasm and just show how it's not being touched by this
totally
lesion?
good. The lesion is touching.
It is touching.
But touching is not compressing. Touching people it doesn't harm them.
We're not getting into that, Andy.
Dear. I'm moving next.
Okay, so the question for the audience is, what would you do next? A, refer to neurosurgery. B, repeat the MRI. C, order a multifocal ERG. Or D, perform additional visual field testing.
Either.
Good.
40 split.
Good.
Any comments?
Well, the additional visual field testing Andy talked about already is really very helpful, because if you see the hemianopsia or the temporal defect with both eyes open, then it's a slam dunk that it's not organic. The multifocal ERG can be helpful because, again, if it's normal, it's helpful to say it's not organic. And if you see some depression in the appropriate area nasally in the retina, then it could be an organic retinal issue. So it's a good split, and both of those may be appropriate.
Yeah, I agree. You know, the most challenging cases that we see are patients that have some real disease and other superimposed non-real or non-organic disease. So I'd be really worried about the visual field, doing the bilateral visual field with both eyes open and seeing a defect there tells you that there's a non-organic overlay to a patient that has an organic disease. The fact that she came in with this workers' comp sort of process should heighten your suspicion. You know, we don't know how heavy that cardboard box was, you know?
She still had no APD. Something's wrong.
And when you say a binocular visual field, are you talking about a Humphrey? And if so, how would you do that? Or are you talking about a Goldman?
We just use the Humphrey.
yeah.
You know how you have to put a patch on the person's eye to test them normally. If you don't, the other eye will cover up the field defect In this case, we're using it the opposite. We're purposely doing the test wrong by not putting a patch over your eye. So we can purposely generate a field defect that is non-organic.
And in this case, we can clearly use the central 24 because that picked up the large defect.
Yeah, so the other field should cover that. That's what we're trying to say. If you keep both eyes open and the other eye truly is normal, that monocular field should just go away. And it's not just for this. Any field defect, it'll be covered up. On the Humphrey, now the temporal crescent, that's not covered. So on a Goldman, if it was the temporal crescent, it would still be missing.
Yeah, so what we've talked about is, in terms of etiologies of a unilateral temporal field cut, asymmetric chiasmal compression or unilateral optic neuropathy, either traumatic from prior optic neuritis or a compressive lesion, should all equate to the presence of an APD and eventual optic atrophy. The temporal crescent, what Dr. Lee was talking about, is from an anterior parietal occipital infarct. This is found 60 to 7 degrees temporally, so actually wouldn't show up on a typical Humphrey field, but can be found on a Goldman. And then there's acute idiopathic blind spot enlargement, which can present with a unilateral temporal defect or enlarged blind spot, variable APD, usually not a brisk APD, but should be associated with photopsias, may have mild dyschromatopsia or mildly reduced acuity. So this patient came in with a diagnosis of a pituitary adenoma and a temporal defect, but really if you take a look at the MRI, you can see clearly that it is not compressing the chiasm, and this is not the cause of her vision loss. And so we talked about a binocular field. She actually just had a regular Goldman field with multiple use of the isopters, and you can see that she has crossing and variable response with the 1,4E, or I4E, excuse me.
Can you point that out, Courtney, to everyone?
So it's the largest one here. You can see with multiple use of it that it expands and then crosses over and even crosses over some of the smaller isopters. So this is not consistent with a physiologic response. So the other option would be to do the binocular field, which should not show the temporal loss with both eyes open.
So,
oh, go ahead.
Did you do the MERG, though?
No.
so what do you think about this? Does this help you?
It's what Lynn said. It could be non-organic, but it could be non-organic overlay. I have something, but I want money.
So what additional testing would you be comfortable with?
MERG.
And if the MERG were normal?
The cardboard box company owes you $0.
And this patient was followed with serial exams, never developed optic atrophy, and had quite variable responses on multiple visual field tests. So her final diagnosis was functional vision loss with non-organic unilateral temporal field depression and an incidental pituitary adenoma.
So I think one of the concerns the audience has is everyone comfortable calling this non-organic? How much testing do we need to do to be comfortable to make the diagnosis of non-organic?
You have to prove they see better than they claim, and they can't have anything else to explain it.
And not just better than they claim, but even better than that, right? They have to be, you have to prove near normal vision or normal vision. You can't just prove that someone who's feigning to be hand motion is 2400, right?
But the Goldman visual field tells you that this is non-organic. I mean, that's a clincher with those overlapping isopters with the same isopter being variable. You already know the patient has non-organic loss. The question is, do they have organic loss, right?
Agreed.
You know they have non-organic loss. So I might not have done the multifocal, but because it's a medical legal sort of that in that category of problems, because it's a workers' comp case, I think doing the multifocal ERG is reasonable.
I have another point, that these patients, once you make this diagnosis, they're yours for life. If we all keep our functional patients and don't make other physicians follow them, we all will see less in the long run and waste less care. So I actually keep them forever and reassure them they're going to get better, and they typically, sooner or later, get better.
You follow these patients for years?
I don't let them go back to any other eye doctor who's going to do more testing.
Would you like some more?
No.
Thank you, Dr. Francis.
Thanks.
The point is, you keep yours too.
Thank you, Dr. Francis.